with this method, we started now analyzing like 17 placements of the screws. And also we presented this at the AAO 2023 in Chicago. And I want to tell you that the procedure is based on CBCT to assess the position of the screw. Then together merging CBCT with intraoral scan, we can receive this from the lab, and my lab is Emanuele Pauletto, so Orthomodule in the north of Italy, is one of the most experts in the world on the placement, of the guided placement of the screws, also with Giuliano Maino. And this is the placement and the positioning digitally planned. Then we go there and we design a template, so a guide that is always a bilateral guide. Even if we place only one side, we use a full coverage guide. And zygomatic extension, you know why? Because when you have a lot of soft tissues, like in the infrazygomatic area, you have to use some extension to move up the soft tissues, because otherwise you engage it in the pathway of the screw. And then this can be printed with the cylindrical guides, these guides, with a window to check the depth of the insertion of the screws. This is a kind of templates that we use also. And this is a kind of insertion that you can see here is with manual driver, because at that time I still didn't have mechanical driver. So I used the manual. That is very, very good control. And you can see, you go deeper and deeper. And you can use this one as a guide for the stopping, to stop the positioning of the screw. As you can see here, only few turns more, and then you can remove the screwdriver. In this case, is orthobone screw, so it's a common kind of implant. Removing the templates, it seems easy, but actually it's easy. And I want to tell you that we also started matching the digital planning with the actual positioning. And the preliminary result was this. We found on the superimposition a discrepancy on the tip that is 0.89 and 0.37 to the cap. That compared with the paper published in the 2022 is even more, is even better. So we can be comfortable, attracted by surgical guided positioning. And now I want to tell you, because I've seen in the Marriott they do something like save the planet, no? I try to save my patient from radiations, no? And actually sometimes when you want to measure something you have to. And I want to tell you that here we are working with Emanuele, with Orthomodule and with Ferrara University with a body scan. So with the body scan you can take intraoral scan to check the position of the screw. And this way you can avoid a secondary CBCT, so the following one. And I want to tell you that the conclusion is that bone screw in the infrazygomatic crest can be unpredictable, the positioning. And it's possible to interfere with the movement of the teeth. And sometimes it's difficult to access that area for the mucogingival tissue. So the guided insertion can be comfortable, can be also reliable, and can be more safe in that area, especially for the sinus. And I want to tell you that the applications, they are a lot, because you can apply directly to the braces. You can apply with a power arm. For example, when I want to move the force more close to the center of resistance, I can bond or I can place a power arm on the screw, on the wire. And we can work with infrazygomatic and buccal shelf screw, for example, for by protruded patients or to close spaces. And you can also combine with aligners. So it's not anyone asks me, okay, you work with this because you work with the fixed appliance. No, I work also with aligners. And you can do this. So you can do this in a comfortable way. So in a guy like this, there is a class 1, and you have a class 2 on the right. You can start working with a system like this with template guiding the positioning of the implant. This is a manual insertion as well. And moving from class 2, going directly to the bracket, then going with a power arm higher with the center, with the line of action of the force, and then getting a first class on the right side, on the left side, to correct this, to convert this class 2 in a class 1. Now the treatment becomes more easy. And I want to tell you that also another kind of point I'm working on is the no compliance sagittal first, because this boy is a good profile, a class 1, but increased overbite, increased overjet, class 2. Okay, I can treat with a kind of system like this with infrazygomatic screw, and then using also sagittal first approach, bonding directly. You can do it very easy, no? With a composite on the canine, and you can move the line of action of the force closer and closer to the center of resistance. Then you can go on with the treatment. You can go on improving and increasing also the loading to 200, 250 grams each side, and getting from class 2 to class 1. So in a way that you don't need collaboration, and is exactly in the way and in the position that is suitable for the distalization